Good morning, everyone. Welcome back to Mount Sinai in 2026 for our Treat Live Symposium. My name's Aaron Fishman. I'm here at Mount Sinai. I'm really appreciative of everyone attending today, and also our staff here, BroadMed AV, for setting all of this up. We have a great live case today. Dr. Lookstein and Dr. Boucher are going to present the case. We also have two guest moderators here today, Dr. Tino Pena from Miami Baptist, as well as Srini Tamala from Florida Vascular Specialists. So I think their commentary is going to be really spot on for the case that we have today. These guys are world experts in PAD. So thank you both for coming. I think without further ado, we're going to hand it over to Rob and get started. He'll show us the case. Thanks, everybody.
Hi, everybody. Can you see us and hear us?
Yeah.
All right, fabulous. So welcome. It's great to kick off 2026 with a lower extremity revasc case. I think it's going to be very interesting, lots to talk about, and obviously thank you everybody for joining us. To my left is my partner, Vivian Boucher, who's helping out this morning. And to Vivian's left is our superstar chief resident, Kishan Patel. Kishan Patel has put together a brief presentation just to get everybody up to speed. Of note, Kishan saw this patient with me in my office hours a few weeks ago, and so he knows the patient very, very well, and it's always great when we can have our trainees have a real true continuity of care from patient intake to intraprocedural care. So Kishan, kick it off.
Sure. Good morning, everyone. So I'll be presenting a case of for lower extremity revascularization. Can we go to the next slide, please? All right, so this is a 7-year-old female with a past medical history of PAD, hypertension, diabetes, hyperlipidemia, asthma, COPD, and had 2 strokes with no residual defects now. She has a prior smoking history, but has quit 20 years now. We saw her in office hours a couple weeks ago. She states she has pain in both lower extremities, right greater than left, and it's present at rest. Also, when she walks about 2 to 3 blocks, she starts feeling it as well. She wakes up in the middle of the night due to lower extremity pain as well. She kind of has to walk a little bit before the pain goes away. For relevant meds, she's on aspirin, Plavix, and atorvastatin. For past surgical history, she had an appendectomy, tubal ligation, but no prior lower extremity intervention was done ever. Next slide, please. Vitals wise, her blood pressure is 133/55, labs moderately within normal limits, her hemoglobin is 10.7. For her physical exam, for neuro sensation, strength is intact in the bilateral lower extremities. For her vascular exam, she has non-palpable pedal pulses bilaterally, but there's no skin discoloration or any ulceration. Next slide, please. So she had some non-invasive vascular imaging done. She had an arterial duplex study done. Basically, on the right, she has a patent right common and external iliac arteries with no hemodynamic stenosis, and similar on the left. Can we go next slide, please? Further down, for her arterial duplex on the right, there's no color flow or Doppler signal present throughout the proximal SFA and posterior tibial artery. On the left, there's no color flow or Doppler signal throughout the proximal SFA. And there's monophasic waveforms in the bilateral lower extremity arteries. For her ABI exam, her ABI is 0.0. It's non-compressible bilaterally. Next slide, please. She also had a CTA done with a runoff. For her right leg, kind of similar, common iliac artery mild multifocal stenosis. Her common femoral artery, same thing. Her SFA was occluded proximally on it with reconstitution with moderate multifocal stenosis in the distal thigh from the profunda collaterals. Her popliteal also had moderate multifocal stenosis. And then her AT and peroneal had mild multifocal stenosis with occluded PT. On the left, her common iliac and femoral had moderate multifocal stenosis. Her SFA was also occluded on that side with reconstitution of the distal thigh from profunda collaterals. Her popliteal had moderate multifocal stenosis. Her AT was occluded proximally, and her PT and peroneal are patent on that side. Next slide, please. So in summary, she's a 70-year-old female with a history of PAD, diabetes, hypertension, and stroke, presenting with bilateral lower extremity rest pain with non-palpable pedal pulses. She had some non-invasive vascular imaging, which demonstrates essentially there's bilateral SFA occlusion and tibial disease and non-compressible arteries on ABI. So our plan today is to go first for the right side because she's having more pain on that side. Endovascular revascularization. We have left groin axis and we're up and over.
Thank you, Keyshawn. Can we go to the first run, please? The first angiogram. We've been obviously working off camera just to try. No, the first one, please.
No,
It's not. It's, yep. Back. Nope. Back. This is the first run. So as you can see here, we're up and over. We have a 7 French sheath, just if you're thinking about technology. And you can see there's a flush SFA occlusion. There's robust profunda collaterals. Next run, please. You see that there's a fairly diseased SFA that reconstitutes distally in the mid thigh, and that disease continues down to about P1 borderline P2, which we're going to have to talk about in just a minute. Next run, please. P3 is wide open, and then you have an AT. There's probably some calcification there in the AT. A moderately diseased tibial perineal trunk. Certainly at the origin, and a perineal that goes down. There's nothing that I would say is named that looks like a posterior tibial artery. Next run, please. This is just the distal calf, and again, you can see that that runoff persists. And next angiogram, please. Of note, and we can talk about this if you're interested. This angiogram, I think, shows what I would consider to be a posterior tibial continuation of the perineal, since there's no PT to think of. I'm curious whether you guys agree with that. And then obviously there's a completely patent plantar vessels, etc. So next, please. So we did a magged up run here, and I think this is just really interesting, is that when we really got to high magnification, you're starting to see what we thought was a sort of starting point or a nubbin for the origin of the SFA, and we really didn't appreciate that when we did the standard low magnification views. Next, please. And we were actually able to get started, and so this is just a standard 035 stiff glide wire into that origin. And we started to progress, and as usually happens, if you're starting with a hydrophilic wire, we went subintimal relatively quickly. Next, please. And next. And so here you can see, I think the wire is about to loop over any second. And we're now in a fairly complex subintimal plane. Next, please. And next. And now we're, for lack of a better word, off the rails. We're not extravascular, but we're clearly in a subintimal space. Next, please. And this is a run through the sheath, and the catheter is clearly not in the true lumen. And I'm going to, sort of fast forward to where we are now, which is that we have a wire down in the calf. You can see that we're, again, still, in the subintimal space. And I think it's probably a good question to at least start. And, Srini, Tino, Aaron, we're looking for any and all advice. We have all the different tools and strategies at our disposal, but we're stuck a little bit here. What would you do next? And I think this is where we sort of like the, sort of teaching portion of this to go. I think all of us have found ourselves in a situation where we're just a little stuck going antegrade down the leg. What would you do? And I'm just going to open it up. And obviously we're more than happy to try and attempt any and all technologies or tricks to allow us to pop back into the true lumen.
and Rob, you did skip one trick that we did already try.
Yeah, I'll keep that for a second. But yep. Tino, Srini, Aaron, what would you all do next?
Well, I'll just start and say, old school. I think the for me at least, the very effective way to do this is to just use an outback. But I'm curious to hear what Srini and Tino would do here.
Yeah, I think that my original algorithm has been to go ahead and try some type of Outback or Pioneer, something to get back into the true lumen or be back. But I think in the setting now, in the last few years, these patients, I've seen that a retrograde approach is something that I may try. What I don't like about this vessel is, there's calcification, it's very calcified. I don't know how successful I'll be to actually, I may get close to the true lumen, but I don't know if I'll be able to get to a place where I can actually extend it up and then capture the wire. So in this particular case, I probably would try to get it back into some kind of um, trying to get something to get back into using a device to get me back into the true lumen. And I think I got plenty of distance of where I am here. I'm probably close to P1. I'm not even probably close, not at P1 yet.
Well, I'm
So
I'm
this
gonna
is
map it out, but I think this is great. Serini, what do you think that we should do
so
next?
the first thing I was thinking about is when I heard that it was an SFA occlusion, but the patient has reported rest pain. I was thinking there clearly has to be tibial disease, which there clearly is. The other thing is the flush occlusion, very tough. Sometimes you can use ultrasound to make sure you're intraluminal at that proximal cap. That's something you can use. I think in this case, you may want to pull back your catheter and maybe start do kind of guide wire escalation, use a higher tip load guide wire, maybe go to an 014 just to try to get into a different plane, like a Confianza, some of the Asahi wires. You can use an Estado, with a little tip, a little curve on the tip. That's what I typically do because more often than not, you can get back into these. What makes this recan tough is that the reconstitution segment is narrowed and diseased, and you're dealing with
Correct.
calcification. And you end up just lifting up plaques and so forth. I think ultimately you may have to go retrograde, Rob. I'm not sure if that's what you're ready to do today. And then the other option, obviously, is using some type of reentry device, whether it's the B-back
So
catheter or, an Outback.
So let's talk about those different options. We obviously have the foot prepped, and we could do that, and sort of explore that as a different option. I'm more than happy to sort of talk through that. But I think the next step would be if we're going to do a reentry situation, would you reenter into that P1 segment, which is at in the sort of middle to bottom of the screen, or would you re-enter in that slightly more bulbous portion in the I would say mid to distal SFA there that's on the top portion of the screen? What are the risks and pitfalls of doing one or the other?
That's a great
I mean,
question. Do you think
not
that
gonna-
that would compromise any of the bypass options in the future? Is that what you're getting at, Rob?
No, I'm just thinking about technical success. I don't feel that, just to be straightforward, I don't think this patient is a fem above knee pop patient. All right, just based on this anatomy, I don't think that's a viable option. I know that's slightly controversial, but I think that if this patient is going for bypass, they're going for fem below knee pop. The P3 segment is the really only healthy segment here. The above knee segment is really not healthy. I don't think that's an appropriate target. I don't want to re-enter in P3. Obviously, I think that would be in the sort of theme of burning bridges. But I think that if we're going to go for a re-entry strategy, I think we have to decide what the target's going to be. Any
I would
comments?
try to, I would try to re-enter at the largest segment of the SFA. That's where I would go with the reconstitution point. Because I think you've
So,
got a
Sarita,
tiny.
can you see the angiogram? Can you see the angiogram?
Yeah,
Put landmarks on it. So
sure, yeah.
you
I
see
would
there
go
the
above.
the easy area would be at the patella P1. And the
Yeah, it's
question
basically
is,
that
do you all
abduction, yeah.
think that's acceptable, or should we go more proximal?
I would go there only because where's your catheter right now, Rob?
Right
Do
now,
you
the
have power?
catheter, I'll show you where the catheter is. Catheter is right there. Okay.
Got it.
And so, as I don't want to really go, farther down because I don't want to extend this further, but you can see that we're, sort of doubling over here. I'm clearly not in the true lumen. I don't want to make any sort of, false, observations about that. What we did was what that Vivian was alluded to is we tried to dilate the proximal segment and sort of see if we could crack through into the true lumen where we're sort of watching it there, but that was unsuccessful. And so that's what we usually do. We took a 4 millimeter balloon, we dilated proximally a little bit. It didn't really help, and so I'm thinking I'm either going to stick the foot now, which again we're totally prepared to do, or to open up an outback because I'm basically here and I've identified the segment that we can pop through for.
I think what I'm concerned about is that flush occlusion where you thought you had already, became subintimal near the origin. And given
Yep.
the appearance of this, the narrowing, the degree of calcification and so forth, I would actually go retrograde first if you're not able to do guide wire escalation from above before I opened up an outback. I'll see what Tino thinks.
Tino, what do you think?
Look, in the setting of rest pain, I think I have very low threshold to go retrograde and give it a shot. But I still think with this calcified vessel, you've identified an area and you're right here. I think trying to re-enter here, especially in that bulbous part, would be a great option. I'm concerned because the catheter and wire's already been in there, and sometimes your wire, it's how to know that your re-entry wire is in where you want it to be. But I think that we kind of mastered that already. So I think I would not go at the P1 like at the patella. I would start above it and give myself that room just in case I don't get it. I work down a little bit until it gives me some kind of a leeway of a couple centimeters to try to get back and recanalize.
Okay.
With the
All right. I think we're gonna go with the reentry strategy because I think it's probably just good to try and show how that's done here. So can I have a Grand Slam wire, please? And then if you could open up the outback. So we're gonna follow Tino's advice, and Srini, there's no disrespect to you. I'm obviously fully prepared to do that, but I do want to be sensitive to the fact that we are recording this, and I think it's a good opportunity to show how reentry catheters work and allow us to be able to make success with that. We are all set to go with that technology. So I think it's an interesting strategy to be able to explore. Since we are getting just everything set up. Yeah, sure. Go ahead.
While you're working, I want to throw out something. This patient has rest pain. Would it be different if this patient had claudication, and would it be different if this patient had, let's say, Rutherford class 5 disease?
So in terms of the
strategy.
So the question is, I think, whether or not you feel comfortable being aggressive with the revascularization. If that's what you're asking. I tend to be aggressive. I believe that we should exhaust any and all efforts to revascularize. I think both of you know me well enough to know that I believe that unless the patient has single segment saphenous vein, that any kind of attempts to revascularize the patient with bypass is going to be inferior to endovascular first. This patient does not have a single segment saphenous vein, at least not in the ipsilateral leg. We could talk about, a conversation about whether or not contralateral is better, et cetera. We're aware from the history the patient has bilateral symptoms. So I am prepared, at least from a pragmatic point of view, to sort of give this patient everything that we've got in order to do an endovascular strategy for this leg and be able to make it work. In terms of what my escalation is, I think that we're sort of down at a place where I'm hoping we can re-enter safely, and we're all set up to go with that. We obviously did prep the foot. I'm going to choose to use that just for this case as the next step in escalation if, God forbid, the re-entry catheter doesn't work. I'm obviously optimistic we'll be able to get it to go. But I think that for the benefit of just educational purposes, showing a reentry catheter is always informative.
So we have
I'm not sure if that's what you were asking, Tino.
That's perfect. We have a number of reentry catheters. How does this anatomy, does it sway to one more than the other? Calcification, the location, stuff like that.
Say that again. I'm sorry, I missed you offline.
Yeah, we have probably 3 or 4 basically reentry catheters. does the anatomy, does the vessel morphology change your decision as to which one to use, or do you like to use one and stick to it and then use other ones as kind of your second and third option? How do you
Can we
how do you
flush the back
recommend
end, please?
people in terms of using basically reentry catheters? Is it something where you need to
That's a
know all
great
three?
question. So I think that from a just a technical point of view, I don't have experience. Our group doesn't have experience with BBAC. I'm sure it's a very good technology. We just happen to just not stock it in the lab, so I can't speak to it from personal experience. We have been users of Outback for 20 years now, and so it's something that we're all accustomed to. It's a sort of go-to technology. We have used Pioneer historically. I find it slightly more cumbersome in terms of the IVUS setup, and I've never felt, just this is my own personal opinion, that it adds that much. I think a fluoroscopic guidance to reentry has always been, very easy for me. I like fluoroscopic guidance for all, lower extremity cases. So at least from my point of view, it hasn't been an issue in terms of being able to either access the target or to be able to successfully do a revasc. So so we're using Outback. I don't again, just to alliterate it a little bit, I don't think that there's so much difference in the technologies that it precludes us from doing this. And I'm going to obviously inject around the Outback through our 7 French sheath, and you both will, all 3 of you will help us decide what the target should be. So we're on very high mag, obviously. And that's pretty close to the bulbous portion. Do you agree? Should I start higher up?
I would start higher up personally. I think you can get
Okay,
into that
that's great.
big lumen.
Like
That kind
here?
of, yeah, I would start where it's very bulbous, like Tino was saying. And I think, for the trainees, we got to think about, look, there's really no data on which one is better than the other in terms of how we re-enter this true lumen. We've obviously got guide wire escalation we talked about. We've obviously got extravascular ultrasound, which we use in our lab a
That looks
lot to
good.
re-enter when we can't tell where the lumen is. You've obviously got retrograde approach, and you've got various reentry devices, BBAC, Pioneer, and Outback. So I think for the trainees, becoming comfortable with one or more of those and becoming an expert at it really makes a difference when you're trying to reenter CTOs that are long segment treated with heavy calcification.
Srini, your advice to trainees would be to become familiar with one specific device. Do you feel like there's a lot of value in having multiple devices available, or do you think one is enough?
I think in this setting, there's other techniques that don't require a device that you can become good at. So I think if you at least understand one reentry device very, very well, I think that can take you a long way. Because I don't think there's much difference in Pioneer Plus and obviously the BBAC catheter different technology.
So this is probably rudimentary for a lot of people, but I just to make it more step-by-step informative, we've advanced the reentry catheter, in this case the Outback catheter, down over a 014 wire. We've retracted the wire to expose the shaft, and I've put this on high magnification so you can see the needle entry path, which is hypolucent on this fluoroscopic image. The L, which is at the tip of the catheter, from a directional point of view, the base of the L is supposed to point towards the lumen of the vessel. If we go back 2 runs, please. Can we go back 2 runs? This run shows that that same L has now a T configuration, and which is designed to demonstrate that it's overlying the vessel. So you want 2 tangential views. You want the so-called T view, which should mean that the reentry catheter is overlying the vessel, and then the L view. And forward one run, please. This is the L view, which shows that the reentry system is next to the vessel. And so once that's lined up, and I'll show this under fluoroscopy, the ideal situation is that you're able to fire the needle, which you see right there. That was the fire. Okay. And then, God willing, the wire is able to progress out the vessel and re-enter the true lumen. All right. And so now what we're going to do is we're going to do an angiogram to confirm that the wire is actually in the center lumen of the vessel, and then we're able to remove the outback and then obviously continue with our procedure.
Looks good.
That's starting to look good.
Yeah.
Great demonstration.
And I just want to make
Well,
sure
that
the
was a
wire
clinic.
is still going.
That was
Okay. And I
fantastic.
believe that we're in the true lumen. All right. And again, I want to be OCD about this. And there's one of the messages I want to really share with anybody who's watching is that never ever be too confident that you are where you think you are. Always really double check and triple check that you're exactly where you are. And
Rob, wouldn't you say
I
that there's a
believe the wire is
tactile
true
feel
lumen.
when you're in the true lumen versus subintimal, even with that 014 wire?
Yes, there is. Obviously, the wire wouldn't be able to go down the anterior tibial artery if we were subintimal clearly as well. And so now, again, retracting the needle, if you can just show my hands, I retracted the needle. And then Vivian's going to help me walk this out, and we're going to watch and make sure we don't lose wire access under fluoro.
Rob, so the 014 wire is obviously compatible with the Outback. Do you want to just tell us why you chose Grand Slam as compared to others?
That's a great question, Aaron. Thank you. So there is concern because you're introducing it through the sharp needle that's at the tip of the system, that if you were to use a hydrophilic wire, a CTO crossing wire instead of a support wire, that you would shear off part of the hydrophilic coating. And so, those wires we use routinely, especially in the below knee circulation for crossing purposes. I've got the wire. To be able to facilitate, and those are the wires. We would use a command wire, a whisper wire, a gladius wire. Those are all hydrophilic coated wires. We don't want to introduce that through an Outback for concern of shearing off the hydrophilic coating. So now, gentlemen, we have let's get back to where we were before. We have a 40 centimeter SFA CTO. We've successfully crossed. What do you think we should do?
IVUS.
Oh, that's great. Can we have an 014 IVUS, please? That's fabulous. I love that idea.
I think you got to IVUS that entry side, that proximal cap, and make sure you're actually not going to jail off the profunda with your revascularization, your ultimate revascularization. And I think you'll probably be okay, but just it's a good double check. You could also use extravascular ultrasound to look at it. But otherwise, there's a great demonstration.
So,
really
so Serini, Tino, Aaron, what do you think you would do in this situation? Just talk through why the origin is so important. Would you default in this patient to a drug-coated balloon strategy? We've got the new RX Rangers on the shelf here, which we think are a great technology. Would you just go full scaffold? And we're a big believer in anti-proliferative technology, and so we'd be thinking about Alluvias there. What would you think about this case with really early Rutherford 4 symptoms and again probably a 35-40 centimeter CTO?
So Rob, I think at the top there, the profunda looks okay. My bias would be to use a DES here all the way to the top, but ultimately I think you got to really take a look at it, like Srini said, and see what's going on at the top there, because that's going to be the critical part of this case, I think.
Yeah, I think you're gonna have to scaffold at least most of this, if not part of it, if not most of it, Rob, because you're subintimal a good length of this CTO. And I think you were saying there's, we'll see here with the IVUS, we'll see the, the length that is how much you're intraluminal, how much you're subintimal. I'm assuming you're subintimal from that flush occlusion all the way down.
The whole way, yeah.
And so I think based on that, you're going to have to scaffold this. I think you got your choices between the two different, DES technologies or Supera, which obviously has good 3-year data as well. But your vessel prep is going to be key here as well.
So in Europe, they would probably do a
Um,
DCB. They'd probably do a DCB and then spot stent. I like the idea of just stenting, but I'm curious what you guys think about that.
I
So,
mean,
so
there is.
Tino, when you say spot stent, would you up at the origin you would stent, obviously,
They would
right?
probably treat the whole thing with DCB and then see where they need the stent, right? Where if it's the top
Yeah.
part, if it's, wherever wherever you see that you may not have the best result.
can we get
I
the
think the
IVUS
key
on
here
one of the monitors, please?
is exactly what we said. It's that top part, that proximal portion, and can you get away with stenting it? Or, sometimes it's so close that you don't want to stent it. You end up, I almost do a reverse where I stent everything but only DCB the
Yeah.
top because I want to, protect
Yeah,
that.
especially if there's a plaque at the top there, for sure, right?
The nice looking vessel there in the
Love that.
top. You look nice.
Yeah, I agree with you. Can you all
So just
see
so the
the
audience
IVUS? I'm
can
just
see,
trying to
the
adjust
IVUS
the
is
room.
the IVUS is at the level of the knee. I can see that on the fluoro, but just to
That's
point that out
correct.
to the audience. Yeah.
Just want to get the IVUS on the big monitor.
So Rob, we can't see the fluoro, so just as you pull it back, just let us know where you are on the screen so we can
All
keep
right,
track.
I'm gonna do a pullback just while they're adjusting our monitors in the room. All right, and so this is going into. You can see there's a lot of athero here. This is into P1, and I'm sort of glad we didn't enter here before because this looks moderately bad. More P1. This is distal SFA. And you can see we're in a very, very diseased artery there. The vein is now at 9 o'clock, just for orientation purposes. And you see, again, there's just a lot of atherosclerotic burden. It is a large artery. And I think that, one thing, and again, I'm hoping you all can comment on that. I've gotten much more comfortable putting in 7-millimeter devices, whether it's balloons or scaffolds, after using IVUS. This is a very nice demonstration of the subintimal channel, which is from about 11 o'clock to about 4 o'clock here. And obviously the catheter is in the center of the lumen. There again, another example, probably 9 o'clock to 3 o'clock of the subintimal, spiral channel there. But
That's our
this is
crossing.
really looking like there we're clearly subintimal with the catheter. The true lumen is now from about 11 o'clock to 3 o'clock. And but this is looking much more like a 7-millimeter artery than a 5 or a 6, and I feel very comfortable probably ending up with some degree of a 7-millimeter implant here. You can see this entire course is subintimal. Now you're seeing the calcification marking the intima at 9 o'clock here as it relates to the catheter. We're in the mid SFA now, and so almost this entire course is subintimal. And to Sereni's point, I'm going to go right up to the origin now, but you can see this entire track is subintimal. We were considering a debulking strategy. And we're a big believer in rotational atherectomy. We actually had Jetstream set up and ready to go, but because we're so subintimal here, I'm not sure that's wise. Here we're true lumen again. I think you all can see that. And you see the circumferential calcification denoting the confines of the artery. Occlusive plaque here throughout the vessel, but again, a very large artery. It's about a 6.5. So if we are going to end up scaffolding, I'm probably going to end up putting in a 7. We're coming up to the origin in just a moment. I think that's the bifurcation there.
So this is great news, Rob. I mean, you're basically interluminal, that proximal, that origin and proximal SFA.
Correct. So
It's
this
subintimal.
is right
Yep.
here, the origin of the SFA. We are true lumen.
Yeah, that's perfect. That's
So-
perfect.
Yeah, we didn't really.
All
I
right.
guess your thought initially, at least when we saw the wire, was that it was subintimal from the top.
Yeah, no, this is
Can we
great.
press record, please?
And I think the key thing here is that, you do have some calcification. It's not very, I would say it's not moderate or heavy. You are subintimal the majority of the way. So I think, there's really no level of atherectomy device that I would use in this scenario. I think we can definitely say that. I would definitely do probably a 6 balloon and balloon the entire length, and then I would probably scaffold the whole thing. Take your pick on device, and what type of scaffold you want to look. There's good data for
So
Superior.
so 6 balloon followed by 7 stent, Srini. Would that be your
Stop
go-to here?
recording, please.
Would you use a
Yeah,
six stent?
I'd probably measure and see. I mean, I typically put in 6s if it's a 6. I mean, I think we know now with some of the early data that we don't want to oversize arteries like we used to think, because that impacts long-term primary patency and
I
so
don't have
forth.
it.
So
Oh,
if
no, I
it
do have it.
measures
Sorry.
6 with balloons
Rob,
of
where are you
6,
going to measure? You going to want to measure the artery real quick on the screen
Yeah.
somewhere?
I'm eyeballing it. It's about a 6.5. We can go through that measurement while we're getting the next setup, but
Right.
I'm going to ask for a 6 millimeter extra long Sterling balloon, please. Okay.
So I would balloon and
So a
scaffold
6 by 150 or a 6 by 200. Again, Serini, I'm taking your recommendation. We're going to sort of prep this with a long 6 millimeter balloon from P2 all the way up to the origin, and we'll take it from there.
And as commonly the case with these subintimal recans, it'll probably look really pretty on that initial balloon inflation, but we know that recoil is ultimately going to be the problem in the long term, and so the scaffold again makes sense.
So what I think we're going to do, just to sort of forecast this, is we're going to do a long balloon inflation here with the 6. We'll do a follow-up angiogram for all of you, get your input about how you would finish the case up, and then we will, sort of stop, just to be respectful to everybody's time. I think these have all been really, really good points, just to summarize several of them. One is that there's several strategies that you can employ when you're facing with a difficult subintimal recanalization for an SFA CTO. I think we were able to successfully use a reentry catheter here, and we're able to establish true lumen crossing. IVUS is absolutely critical because as we've been talking about, it's so impactful not only for you to determine the size of the devices you're going to use, whether it's balloons or scaffolds, but also to determine potentially how you're going to end the case. And clearly, if you have a subintimal entry, you're going to have a very difficult time sort of finishing off the case with regards to compromising flow to the profunda. And then obviously, it goes without saying, we don't like to burn bridges here. We obviously respect our surgical colleagues, and there's clearly benefit towards bypass. But we had, I think, a very, very healthy conversation about what the appropriate site for reentry should be in an ideal situation, so that we don't unfortunately find ourselves in a situation where we're converting somebody from one form of bypass revascularization to another. So again, we're starting really at the bridge between P1 and P2. This is a 6 millimeter balloon. We're going to take it up to.
Do you guys want to switch back to the fluoroscopy image, Rob?
Yeah, can we go back to fluoro, please?
Yeah, thanks. That looks great.
So this is the balloon going up. I think you can see the reentry tear, the reentry site, just above the medial portion of the femur, but we're getting pretty uniform inflation here of the balloon, and this 6, honestly, for me, looks a little bit undersized. I think this could have taken a 7, but I think 6 is a good place to start. I'm certainly glad we didn't start with a 5. Just as an example. And I feel much more comfortable starting with a 6, to Sereni's point, because of the IVUS.
Rob, maybe we can talk about your thoughts on medical management post-intervention now, because that's obviously something that's become very important over the past, year and a half. What is your plan once you're done with your revascularization, and typically?
Yeah, that's a fantastic question. So in an idealized world, we would want everybody on a PAD dose DOAC and an antiplatelet regimen. That's easier said than done. I've gotten accustomed to sort of discharging patients on dual antiplatelet therapy, and then seeing them in the office with the duplex to make sure that the revascularization is open, and to then determine whether or not they can be switched over, and that has to do with their level of compliance, whether or not they can tolerate it, whether or not their insurance will be able to manage it, et cetera. And I'll just tell you anecdotally, based on the population that I see in New York, about half my patients still are on dual antiplatelet therapy, 1 year, 2 year, 3 years out, and another half have been switched over to most commonly low dose Xarelto, and a antiplatelet agent. And my preference in that situation is clopidogrel over aspirin alone. I don't know what you all are doing, Tino or Serini, for your medical management. We also obviously very closely monitor a patient's lipid profile, and we've gotten much more liberal about prescribing or making recommendations for prescribing Repatha for a number of patients, certainly statins. We want to make sure that they're not smoking. Those are all critical considerations, but I think at a minimum, it's antiplatelet therapy and a DOAC.
Yeah, I agree with you on that. We pretty much do. I like to start with dual antiplatelets. If I can get a Xarelto involved, I will, and then and go with a baby aspirin. But I like to reassess them 4 to 6 weeks is kind of when I see them in the office, and at that point, kind of make a decision. Right? There's depending on what I did, some of those patients may go to a single agent, some of those may stay with a dual agent, and we'll see how it goes. Depends on their history, how many other interventions they've had.
Yeah, I think
So I want to
our
bring
practice-
Vivian into the conversation just quickly, because she's been helping me get this done all morning. Vivian, what are you thinking about this case? You've seen how hard it's been to open her up. Are you leaning more towards a scaffold or more towards a DCB strategy? How are you thinking about it?
I think given the length, having a scaffold is probably really necessary for her. And I think,
are you thinking full metal jacket, or are you thinking we're going to spot stent? What are you thinking about?
I think we're gonna, given the calcification and everything, we're probably going to just extend throughout the entire segment.
Srini, did you have another comment?
No, I was just going to say, I think that's one of the challenges, when we look at the data for medical management, using low dose rivaroxaban and low dose aspirin, is that one, it's, compliance, two, it's cost, three, it's getting approval. I think a lot of people have, used the strategy that you and Tino have talked about with, dual antiplatelet first, and then see them at a month or whatever your follow-up period is, and then determine at that point, also taking into account their bleeding risk and so forth. I mean, one of the problems we're having is most of the patients we're seeing, their diabetes is not controlled, their blood pressure is not controlled, they're on a low dose statin that's not doing the trick. And I think we all know that you really have to put these patients on high dose statins and really get their LDLs down. Maybe following some of the European guidelines, under 70 ideally, but if as a physician, if you don't feel comfortable doing that, obviously you can send them to their primary care doctor or an endocrine doc or somebody that you know well. But I think getting those other things like diabetes, hypertension, and hyperlipidemia under control, that ultimately, as we all know, affects your primary patency rate. We have seen patients who, because they just have this diffuse inflammatory process throughout the body that's just completely active, and if you don't get those under control, you're going to really have an early thrombosis or early intimal hyperplasia of your stent, and restenosis becomes a factor. So I think very important thing to think about.
All right, so that was a 6 millimeter semi-compliant balloon, probably up to about 6'3", and this is the angiogram. And as predicted, it looks good, but certainly not great. It's difficult to say that we would stand alone, but I think this is a great, conversation about, with this kind of luminal gain, with this kind of understanding about the subintimal passage, are we comfortable with a DCB strategy, or do we think that we should scaffold a significant portion of this in order to provide this patient the most durable results? And again, I'm open to any and all comments. You're seeing it
So,
while we're actually looking at it. So
You could see the extent of the collateral still there too. I think if we did IVUS, you'd appreciate that isn't that much luminal gain probably, you know?
that's
So
a good point. It's a really good point. So on a positive note, the runoff is completely preserved,
perfect.
which we commonly see in a subintimal recanalization and a reentry, that we don't have distal embolic complications. But again, I'm curious. Do you all think we should IVUS again and then make a decision, or do you think we should try DCB and see what it looks like, or just start opening up the drug-eluting stents?
So,
Rob,
so
I
Rob,
think
my vote's going to be DES, and I think the only question is what size to use. Honestly, I sort of wanted to see that measurement on the eye, but I think you said you were comfortable with the 7. I think either one would probably be
Yeah.
okay here. What do you guys think?
I want to go back to Rob's question because I think he's right on in terms of your decision-making process and the approach to this case. Started with a 7 French sheath, everything was in play, right? You crossed, you even got recalcitrated, still everything was in play. You did your IVUS, you did your angioplasty, and now you're making your decision. Am I DCB? Am I going to go to, keeping all your options, as opposed to a lot of times people make their options even before they start. I'm going to end up stenting this case. I think everything is in play. And I think after this angiogram, to me, this is a scaffold. This is a drug-eluting stent. Just by the amount of irregularity, the dissections I see, I don't think a repeat IVUS is going to help me much more, other than sizing, which I think I'm comfortable with a 7. But I like the approach and keeping things open, right? As opposed to deciding before you start the case what you're going to do. You had all your options open. You had the right size sheet that you could do everything to your disposal. And now you're really making the decision as you progress. And I think this, to me, is going back to that 7 mm stent.
Yeah, I
Srini.
agree. I think the angiogram tells you enough. You've got multiple sites of recoil. You've got spiral dissection, which we'd expect after that recanalization. You've got a good landing zone proximally, for your scaffold, and I would definitely scaffold this. You could
outpatient?
discuss whether you use Illuvia or Zilver or Supera. You could probably have a discussion about that maybe offline or a different time, but I think you have to scaffold it.
Yeah, I think those are great points. My own personal politics is I've not been as impressed with the interwoven stents for this long a lesion. And I think for short focal lesions, especially across P2, I think interwoven stents are spectacular. But as soon as you get to 25, 30 centimeters, I just have not been really impressed with the durability. And I think there's just more and more and more data coming out about long use of a drug eluting with a polymer, paclitaxel eluting stent. So that's just where, from my experience, that we've sort of fallen into. I think all the strategies are very, very helpful. On that note, I think I'm going to, sort of wrap this up because I think I don't want to keep you all here to watch us just put in stents. We'll obviously film the final angiogram and give a summary of what we've done, but this has been a fantastic conversation. And I for one, want to thank all of you for joining us this morning. I want to thank my partner Vivian for keeping me out of trouble and keeping me honest. I want to thank Keyshawn for a great presentation and all the assistants. I want to thank our incredible techs and nurses here at Mount Sinai IR Room 1, our support from our anesthesia colleagues. And then, Aaron mentioned it before, BroadMed AV just does such a great production job from the video and the audio, and have just been great partners with us for the last several years. So thank you all very, very much. Any last closing comments or questions from the moderators?
Great case,
Rob,
Rob.
this is a great case, and I really think the educational value is tremendous. I've already gotten several texts about it while you're doing the case. Please film the final angio so we can put them in the final video product for everybody to see.
Absolutely.
Karam, Vivian, great job. I think it was fantastic from beginning to end. Really a lot to learn, a lot of things to go through, and the decision-making process is that's really the key, I think. And thank you again.
Thanks. Yeah, thanks for having us.
Thank you all. Thank you for joining us this morning. Have a great weekend, everybody.